Good afternoon, everyone. Our heartfelt gratitude for everyone who has joined in today. Niti Manthan is an initiative to motivate and inspire young students on various socio-legal themes to guide them transverse the righteous path via teachings outside of a traditional classroom. Having a direct interaction and the exchange of views with experienced professionals is the aim to achieve the holistic growth of all young minds. This think tank currently functions in the areas of, but not limited to, summer schools and internships, pro bono e-classes and lecture series, young leaders for legal literacy program, research center, skill building workshops, journals and blogs. Sushruta, the Center for Medical and Health Law Ethics Studies at Niti Manthan, is an initiative that began in September 2020 with the aim to collaborate on the complexities of legal rulings and medical issues for young upcoming professionals to have open conversations towards effective policy making in the healthcare sector. In pursuance of this goal, the center encapsulates operations including internships, tabling policy papers, empirical researches, and other awareness initiatives such as competitions and expert webinars. Our ongoing research project, Public Health Federalism, has given us this opportunity to connect with our expert speaker for today, Dr. Shankar Ghosh. For this webinar with students and professionals of diverse fields on the topic, Public Health Federalism in India with special focus on vaccination. Sir is a senior advisor in vaccine delivery at the Bill and Melinda Gates Foundation. He is a public health physician with 30 years of experience in primary healthcare and infectious diseases. His primary interest is in infectious diseases and vaccine delivery. Prior to joining the Gates Foundation, Sir was director of the regional vaccine delivery work of PATH in South Asia and Western Pacific region, focusing on new vaccine introductions. He has also served as a regional coordinator of the National Polio Surveillance Project of WHO in India. On top of all, he is an honorary fellow of Indian Public Health Indian Association. We are honored to have you amongst us today, and with this, I pass on to you to address our audience today and share your expertise in the field.
Have some question answer session later on after the presentation. We have about 45 minutes, and unfortunately, I have another engagement after 45 minutes, so I will sign off after 45 minutes. But I have the presentation for about 25 to 30 minutes, and then for 15 minutes we can converse. So then, with your permission, then I will start the presentation that I have, and then probably we will take to the questions. Now, let me get to the presentation. Just give me a moment. No, this does not come. Yes. Just give me a moment. Yeah. Is it visible now, the presentation?
Yes, sir.
Okay, good. Okay, so we are going to look at immunization in India, looking through a public health lens. So the discussion that we will have today is around the public health principles for immunization. We will have a very brief look at the immunization program in India, which is called the Universal Immunization Program, some of the recent advances and the journey that it has traveled till date. And finally, we will have a few sort of discussion points around looking ahead as to where the immunization program is going. As you will see that we have not touched the COVID vaccination program in today's conversation because that does not fall in the routine immunization program. However, after the presentation, if you have any questions which I can answer, then I will be very happy to address that. Before going into public health and immunization, let us look at what public health is. Sir Donald Acheson was the public health specialist in London, and managed UK's public health program for a long part in the 20th century. So he defined public health as an art and a science of preventing disease, promoting health, and prolonging life through organized efforts of the community. We all know what health is. Health, as defined by World Health Organization, is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The question that we need to ask is, what is public? This is the most important component of public health, because public here refers not to one individual, but a group of people. And secondly, public refers to a collective action and not to an individual's action. It is expected that multiple individuals will act in a synchronized manner, in a collective manner, in order to have the impact that public health desires to have in whatever field it is working. Therefore, public health is the collective action of the state or any agency, be it private, be it autonomous agency, that focuses on the health of a community. It does not focus on the health of an individual. However, a community is made up of individuals. Therefore, individuals are also impacted by the positive outcome of public health. Second. Now we come to immunization as a public health program. So immunization, if you see, it fulfills all the criteria of public health. It protects communities from infectious diseases. It promotes good health in a disease-free environment. And finally, it prolongs life by securing the population from diseases. If you look at today's example of COVID-19 pandemic and the role of public health, it is helping people to be protected from the infectious disease through the use of mask, sanitization, social distancing. By doing that, it is promoting good health in a disease-free environment wherever we are able to create it. And finally, it is helping through vaccines to prolong the life of the population from the disease. Immunization is also a perfect blend of science and art that we discussed in public health. The science of vaccines is administered through the art of delivery. Delivery of vaccines is an art, and that we will see a little later as we go deeper into the presentation. Finally, immunization is also a public good. As we shall see, subsequently, it has a high economic return for the society. It aims to eradicate, you know, of the polio story, of the smallpox story, eliminate and control infectious diseases from the world. And ultimately, it also contributes to an overall strengthening of the health systems of the country. So what are the principles of an effective vaccine delivery? Let me tell you a small, short anecdote from about 30 years back when I was working in an NGO in Rajasthan, in the deserts of Rajasthan. So I used to work in the Churu district, managing 50 villages for their public health, primary health care program. And this was around 1992. So there were 3 villages which were, very difficult located, and they were having very poor coverage. So we sat down one day in order to plan how to accelerate the program in those villages, and additionally also look at some of the other underperforming villages and how we could improve the program. So for 2 to 3 hours, we drew maps on paper. We sort of planned the transport. We discussed about how to, mobilize the population and all of that. Then, during lunchtime, when we were having lunch and we were discussing as to how to move forward with this, one of the ANMs, which is an auxiliary nurse midwife, whom we call a health worker, a lady health worker, she said that, if you close your eyes and think about vaccination, what do you see? Ultimately, there are only three things that we will see if we close our eyes and think about immunization. One, we will see a vaccine. Second, we will see a place where the vaccine is being given. And the third, we will see that there are some vaccinators who are giving the vaccine, and there are some people who are receiving the vaccine, primarily children. So therefore, from there, we constructed a 3P pillar based on which effective vaccine program will be carried out. This 3P pillar has stood for all the programs around vaccine delivery, be it routine immunization program, be it campaigns, be it COVID vaccination. And what is this 3P pillar? The first is a product. We need to have a product that is efficacious, which is available, and which is affordable. The second is we need to have a place which is accessible and acceptable to the public. And the third, we need to have three sets of people. One set of people who will vaccinate, one set of people who will come for vaccination, and a third set of people who are generally the local population who will mobilize the people to come for vaccination. They'll go to the house, they'll call them, they'll tell them that today is the date for vaccination, please come, and so on. So therefore, if we have the supply of a safe and efficacious product, which the government or private sector can afford, if we have a clean place that can be reached by people, and if we have people who are knowledgeable, people who are trained to give the vaccine, the program is complete. We just need to have these three things. Therefore, if we define what is effective vaccine delivery, it is primarily the availability of a safe, efficacious, and affordable vaccine at a place that is accessible and acceptable to the public, where trained health workers deliver vaccines to people who are well informed about the vaccine, which they or their dependents receive. This is what is effective vaccination. Now we will look at vaccines across a 3D lens. Now, vaccine is a product that we have seen. It is a scientific product. The first step that happens is that there is a molecule that is identified, which then goes through a whole development process, which now all of us know about: the vaccine trials, the studies that have to go, that one has to go through in order to develop the vaccine. Then the vaccine has to be manufactured. After all of this is done, then there is a regulatory approval of the vaccine, which we are calling decision on the vaccine. And finally, then once it is decided to introduce the vaccine in the program, the vaccine is delivered. Therefore, we have development, we have decision, we have delivery. India is one of the world's largest vaccine manufacturers today for routine immunization and also for COVID vaccination. Vaccines developed in India are delivered directly by the country or the manufacturers, or through global bodies like Gavi, to low and middle income countries, primarily in Africa and in Asia, in Latin America, but across the world. Today, it is estimated that about 60 to 70% of vaccines supplied to low and middle income countries come from India. And this has just happened over the last 20 years. Before that, India was not the major supplier of vaccines in the world. Vaccines from India also meet global standards of quality because they have to be passed by regulatory agencies globally, by WHO, by Gavi and others. They are safe, they're affordable, and their affordability is one of the main reasons why they are so attractive to low and middle income countries. And they can be supplied to the most remote parts of the world. The India's regulatory body is called the Drug Controller General of India. It is a global standard body which is reviewed by WHO periodically in order to ascertain its quality. Very recently, 2 years back, in 2019, WHO reviewed the Drug Controller General of India, and Drug Controller General of India got one of the highest ratings that WHO gives in terms of its quality and in terms of the efficiency of the body. Now, before I move to the next slide, we need to understand that how does a vaccine get introduced into a program? I don't have this on a slide, but I'd like to tell you. So the whole thing starts with something which we call a P cycle. The P cycle is a cycle through which a new vaccine, like a COVID vaccine or a pneumococcal vaccine, is introduced into a country's health system. And this is not true for India only, this is true for across the world. The first P is a problem. There needs to be a public health problem in the form of an infectious disease, which will trigger the need for a vaccine. The second P is that problems, they never happen singularly. That is, it is not that a country only has malaria, or a country only has pneumonia, or a country only has measles. There are multiple infectious disease problems that the countries have. Therefore, the country, based on the data that it has on the problem, must prioritize the problems, which is having the most impact on the health of its citizens. Therefore, the second P is prioritization. Once the prioritization is done, then this is placed before the policy-making body and a policy is taken. So the third thing is the policy to introduce a vaccine against the problem or the prioritized problem so that the problem can be controlled. After the policy is taken, there is a lookout for the vaccine, which is the fourth step, a lookout for the product. Once the product has been identified wherever globally, maybe within India or outside of India, or anywhere within the country or outside the country, then one looks at the price of the product. Can the country afford it? And that is our next P, the price. Once we see that the price of the vaccine after negotiation and everything, we understand that this is the cost of the vaccine and the country agrees to introduce the vaccine, then comes the question of where will the fund come from? That is our next P, which in case of India is where will the paisa come from? Now, once it has been identified where the paisa is coming from, whether it is from the government or it is from donor agencies like Gavi or WHO, once that paisa is identified, the next step comes is procurement, our next P. Once procurement is done, then what happens? Based on the product, the vaccine, a planning is done, which is our next P. Once planning is completed, the vaccine is rolled out into the program, which is our last P. Now, once we get into the program, we identify new problems and the cycle continues. exactly what is happening in case of COVID. We had a problem, we prioritized the problem, we took policy decisions on it, then we looked for products, we looked at the price of the product, then once we looked at the price of the product, we identified the paisa. In this case, the government is providing the paisa. Once the paisa was identified, procurement was done. Once procurement was done, planning was carried out, or procurement was planned, planning was carried out, and then once planning was completed, it was introduced into the program. And in the program, now we are seeing that there are certain problems that are happening, and based on that, newer plans are coming up. Now we will go to the next part, which is an overview of our universal immunization program. Give me a second. So India's universal immunization program annually targets about 27 million newborns, 26.7. This keeps on varying. About 29 million would-be mothers to be delivered through 12 million immunization sessions, which are linked to 28,000 cold chain points and storage of distribution of the vaccine. So therefore, we have 27 million, 28,000 cold chain points, 29 million mothers, and 12 million immunization sites. There are 10 vaccines in India's universal immunization program that we all know, from the BCG for tuberculosis to polio to measles to pentavalent vaccine. There is one vaccine, which is the Japanese encephalitis vaccine, which is given only in districts where the disease is endemic, which is in eastern part of Uttar Pradesh, some part of Bihar, some districts of southern India, some districts of northeast India, and all of that. There is one vaccine, pneumococcal conjugate vaccine, which is currently available in UP, Bihar, Haryana, Madhya Pradesh, Rajasthan, and Goa, and will be scaled up probably by the end of this year to across India. That decision has been taken, the funding for that has been made. And finally, there is one vaccine, which is an HPV vaccine for cervical cancer, which is available only in Sikkim as a state vaccine. The state is procuring it, and in some districts of Punjab state, where it is given as a state program immunization, state immunization program initiative, and not a part of the national initiative. So what have we done over the past 35 years in terms of our vaccination program? In 1985, the vaccines were introduced against 6 vaccine preventable diseases: measles, diphtheria, pertussis, tetanus, tuberculosis, and polio. Then many, many years after, in 2002, we introduced the hepatitis B vaccine. In 2006, we introduced the Japanese encephalitis vaccine. In 2010, we introduced the measles second dose, and the hepatitis B was scaled up across the country. In 2011, a vaccine called pentavalent vaccine, which had the DPT vaccine and 2 other vaccines along with it. Then we have the 2013, when the JE second dose was introduced into the program. In 2015, the inactivated polio vaccine was introduced. In 2016, a rota vaccine was introduced. 2017, a rubella vaccine was attached to the measles vaccine. The pneumococcal vaccine was introduced. A JE adult vaccine was introduced. And in 2018, the vaccine that was introduced is the tetanus and diphtheria toxoid vaccine for all pregnant mothers, replacing the tetanus toxoid vaccine that was given before. In 2019, we scaled up rota vaccine across the country. The whole country has it now. In 2021, we will scale up pneumococcal vaccine across the world. The only vaccine that will now be remaining to be scaled up, introduced and scaled up, is the HPV vaccine, which is the cervical cancer vaccine for women and men, adolescent girls and boys. Now let us look at some of the triumphs that have happened in the immunization program in India. The biggest triumph that we know is of the smallpox eradication long back. On May 24th, we saw the last case of smallpox reported from India. There's a very good quote from Dr. Larry Brilliant, who was working in the India's smallpox immunization program. The rapid eradication of smallpox from the place that was for many years the world's principal endemic focus of the disease has been singled out as one of the great victories in the history of public health. Only 12 months separated a peak of 8,000 infected villages in May 1974 and 188,000 cases in that year from the last indigenous case in May 1975. In 12 months, our health workers completely wiped out smallpox, made 8,000 infected villages free, and there was no case reported after May 24th. This is one of the monumental triumphs of smallpox eradication from India. Then we come to polio, the fight against the wild polio virus. We saw the last case on January 13th in 2011. This was a girl from Howrah district of West Bengal. The girl's name is Ruxar. I had met Ruxar 2 years back when we did a photo exhibition of public health in India. And when I asked her that whether she has visited Delhi, this was her first visit to Delhi. And I asked her, what do you want to do in Delhi? She said that I want to climb the Qutub Minar tomorrow. And the next morning, she was taken to Lal Killa, she was taken to the Qutub Minar. She did not climb the Qutub Minar, but she was very happy when she returned to Howrah, and she had spoken to me before returning. She was very happy that she had seen the Qutub Minar. Then one of the triumphs of immunization in India is protecting our mothers and the newborns by eliminating the maternal and neonatal tetanus from the country. India successfully eliminated neonatal tetanus in 2015, and this actually means that the maternal and neonatal tetanus is reduced to less than 1 case for 1,000 live births that happen in the country. And here you can see our honorable health minister, earlier health minister, Mr. J.P. Nadda, receiving the certificate of elimination from WHO, CRO director, Dr. Poonam Khetrapal Singh, and Margaret Chan, who was the Director General of WHO during that time. Then we come to the triumphs of immunization in India. India conducts world's largest campaigns. The Pulse Polio campaign, which targets more than 172 million people, started in 1995. The Measles Rubella campaign, 410 million, started in 2017. The intensified Mission Indradhanush, this inoculates about 1.2 million pregnant women and around 6 million children in 2017. And COVID vaccination, you all know what is the target, 300 million, and we have launched it in 2021. India is one of the most famous in the world because of the robustness of its campaigns, because of the planning, the coverage, the quality of the program that we conduct across the world. And finally, I will say one of the biggest prides that probably as an Indian citizen we can have is around the Vaccine Maitri or Vaccine Friendship program of the government. There is a link here. I'll share the presentation later on. You can go and look at the link. 6 crore and 45 lakh doses of COVID vaccine made in India have been supplied to 84 countries and to the UN peacekeeping force, facilitated by the government of India and the manufacturers from India. And as UN's Chief Antonio Guterres said, is that we are extremely grateful for India's 2 lakh coronavirus vaccines for the peacekeepers who are working in Afghanistan today. So moving forward, how do we take India's immunization program forward? India, as you see, has made exemplary progress in the last decade with focus on scaling up the portfolio of vaccines, the number of vaccines, and also the coverage and equity. Now we have a very secure supply of vaccines from our domestic manufacturers. We have introduced the essential vaccines, all of them in the program. We have also strengthened our immunization systems by augmenting the vaccine safety surveillance, which means that, if there are any adverse events following immunization, by introducing multiple innovations like the electronic vaccine intelligence network, which is a real-time check on vaccine availability at the cold chain points, and from which, we have now developed the COVID software, which many of you may be aware is being used for the COVID vaccination. And then the third thing that we have created multiple new channels of social mobilization in order to improve the demand of the vaccines in the community. But we have challenges, and we call them the 3A challenges. India has improved immunization coverage, as we saw, rapidly over the last 5 to 6 years primarily. Now we have more than 80% government reporting data. Independent surveys show between 67 to 70% of coverage that India has achieved. However, this is not enough. We as a nation have taken a pledge that we will have not a single eligible child left behind with vaccination. All the states are striving to do that. It's a monumental task, and that is where the challenges come up. We have to remember that there are two plays in any program delivery. One is the supply and access, and the second is demand. If we cannot create demand, then we can take the vaccine to the population, but the population will not take it. And finally, the 3A challenges that we have, one is around the access to vaccines. There are very difficult areas. There are working parents who cannot take the children during the scheduled hours. Therefore, we have to have innovative plans to overcome this. The second is around apprehension about vaccines, because some people hear rumors about vaccines and then they do not want to take the vaccines or take their children to the vaccination center. And finally, the awareness about when the session is taking place, what vaccine is being given, when it is being given, all of these need to be conveyed to the community. So moving forward, immunization must come as a diagonal intervention. For a very long period of time, we have used immunization as a vertical program where from the manufacturer, vaccine is collected, goes straight to the centers, and it is given to the mothers. But with our focus on universal healthcare and primary healthcare, this is no more being possible. It is not sustainable. This has to be integrated within the larger universal healthcare and the primary healthcare. Therefore, with our understanding of public health and the focus on universal healthcare and primary healthcare, we will have to find the space of immunization in the urban healthcare. And with our rich experience of immunization, it will be a driver of the urban healthcare, which is now forming, and will strengthen the health systems in the process. Therefore, immunization will not be a vertical program. It will not be a horizontal program cutting across all the segments, but it will be a diagonal program which will focus on driving the universal healthcare and strengthening the health systems at parallel. We need a 4I platform in order to do that. The first I is integration. Immunization must be integrated in the primary healthcare systems, where there'll be a diagonal approach, the one that we talked about, with a horizontal focus on strengthening systems, and a vertical focus on coverage and equity. Innovations must be brought in to address the bottlenecks around access, apprehension, and awareness that cannot be solved by existing solutions. The third is that we must continuously get good data to measure the impact of immunization. And finally, it has to be institutionalized so that domestic institutions within India, at the grassroots level, at the district level, at the state level, national level, can drive the immunization program and own the program as a country's universal healthcare program and not supported by external international partners anymore. We owe the immunization program to our healthcare workers. This is a picture that I had taken in Maharashtra, Mumbai, where you can see a healthcare worker in a very hot summer afternoon speaking to mothers about the importance of vaccination. And such healthcare workers across India travel to very deep parts of the country. I can show you hundreds of photographs of that, where they go, risk their lives across difficult terrains to give vaccination, to motivate mothers and parents to take their children to the vaccination site. And vaccination rhymes best with celebration. We can see a celebration happening of the children who have been recently vaccinated with the measles and rubella vaccine. And this picture I had taken in Uttar Pradesh, in Lucknow, in a school where the children were so happy after receiving their vaccination and they were sort of celebrating. And this was a very happy moment in the program. So thank you. I am over from my end. Now we can take questions on the presentation and if any other questions that we have. And we have around, I can take around 10 minutes.
Thank you so much, sir. It was a truly insightful session. And we do have some questions in the chat box. The first is by Dr. Siddharth, who is asking, how effective is the vaccination with the new strain of COVID cases coming up? Should we vaccinate with the old strain and risk the exposure?
Good question. Now, this is a question that is currently being, and I'm assuming that you're talking about the COVID vaccine. And this is a question that is, being understood or is an evolving question across the globe. There are multiple strains that have now developed. There are, as you know, a Brazilian strain, there is a South African strain, there is a UK strain, there's a strain which is now in India. There are multiple views on this, and whatever views there are, all these views are based on some of the scientific assumptions that we have made. There is no definitive answer to this, the question that you ask. The only answer that is there is that if we do not vaccinate at this point of time, we have a huge risk of exposing us and the community to COVID infection. Whether this will compromise anything with the future strains or the future protection or the efficacy of the vaccines is a question that cannot be answered today. We have some past experiences of the multiple strains of the viruses. Also, we have seen in case of polio certain strains and things. But overall guidance from WHO, from all leading scientific experts, and from the government of India is to continue the vaccination process and have as many people vaccinated as rapidly as possible.
So the next question is from Yash Kulshesh, who is asking, India's COVID vaccination program has been focusing on senior age groups since January. But with cases rapidly increasing, should the age limit be relaxed and everyone above 18 be allowed to get the vaccine? What's stopping India from implementing that?
Fantastic question. Very good question. Who asked this question? So there are three things that we will have to keep in mind. If you remember the P cycle that I had talked about, there is always a question of prioritization which comes when there is a problem. What was the prioritization criteria that we began with in January? The prioritization criteria was saving the most vulnerable. And the most vulnerable were the elderly and the ones who had comorbidities and were above a certain age. Therefore, they were prioritized. Whether it is a right decision, whether it is a wrong decision, there are lots of debates that can happen. But because we did not have the unlimited vaccine supply, we needed to prioritize and we needed to take a decision. It is a decision that the government had taken. As you know now that we have expanded the program to above 45 plus, everyone can get the vaccine. The challenge is, yes, everyone above 18 years should get the vaccine. The unfortunate part is that we don't have the vaccine in India. If you look at whatever is published in the media, even if I don't speak about what is there in the government's, internal circles, which I don't know of, I know what is available in the media. A simple thing that is there is that we are seeing that there is around 70 million of Covishield, around 15 million of Covaxin. These are the two vaccines which are available, which adds up to 85 million, which comes to, which I'm speaking of till June. And if we see the coverage, we are seeing that per month, on an average, 90 million are going to get vaccinated. Therefore, we have a shortage. How we will manage this shortage, that, various brains within the ministry are certainly looking at it. But at this point, we don't have the luxury of expanding our vaccination program. Whether we failed in our planning, whether we should have ramped up production, those are criticisms that we can have at any point of time. Answering your question, we don't have an option. Whether we should have it, whether we should have 18 plus, yes. Can we do it? No.
So the next question is from Architi Batra, who is asking, how important is it to engage policymakers at the outset to guide research in the public health sector in India? How can a student who has interest in policy making but has not studied medicine work in this field with government agencies?
Very good question. Very, very good question. So the policy making process for vaccines in India is done by something which is called the NTAGI, which is the National Technical Advisory Group on Immunization. The NTAGI has multiple subcommittees. The subcommittees sit in the Indian Council of Medical Research. Now, Indian Council of Medical Research is our apex body as far as any medical research is concerned. Anything that has to do with development of a medical product is done by the Department of Biotechnology. These are the two platforms where it can be done. Now, there are multiple channels for young individuals who are out of the medical background to get engaged in this. One is that the Indian Council of Medical Research and the Department of Biotechnology both have something which is called the Grand Challenge. The Grand Challenge is an offer to the young and the entrepreneurial minds to submit proposals, which will be reviewed by these bodies, and they will sort of either include them or sort of park them for later use. But that is one channel. The second channel is a direct communication to Indian Council of Medical Research through various platforms that are available on their website, also on the Department of Biotechnology. Bottom line, I completely agree that the policymakers need to be very closely associated with research. The good point is that they are, because Indian Council of Medical Research is very much involved in the policy making process, and they are our apex body. Therefore, they are involved in research as well as policy making.
So this question is from Aditya Kumar Jha, who is asking, are people still getting COVID after taking the vaccine?
Yes, absolutely, they're getting. Even after 2 doses of the vaccine, they are getting the COVID, and we had expected this because one needs to understand very clearly about what COVID vaccine does. COVID vaccine to an individual is that it does not stop the person from getting the vaccine or getting the virus or spreading the virus. What it does is that it protects the individual from severe disease and serious disease. If I can take 2 minutes in order to explain how does a vaccine work? A vaccine works as an antigen. What does it do? It does three things. One, it sort of introduces the infectious agent to the body. It says that this one is a foreign. This is a foreign agent. This is a stranger to the body. Please recognize it. The second thing, what it does is, after the body's immune system has recognized the stranger, it kills the stranger, shows the body how to kill the stranger, the mechanism of killing. It teaches the body. And then the antigen goes off, the vaccine kind of goes off, but the body remembers. Then, if in the future any further stranger in the form of that antigen comes, then the body responds to it and tries to kill it. Therefore, the stranger always comes. The infectious virus will always come. They will cause some symptoms, but they will not be able to create major problems because they will be killed before, or they will be neutralized before they can cause any serious events in the body.
So this was all for the Q&A session.
Good.
I now invite Pratik Mudgal, our core team member, for delivering the thank you note.
Thank you.
Greetings of the day to this August gathering. Pratik Mudgal, core team member of Sushruta Niti Manthan, feel glad and honored to offer a vote of thanks on behalf of the organizing committee. First and foremost, I would like to offer my heartfelt thanks to our learned speaker, Dr. Shankar Ghosh, who spared some time from his busy, let me emphasize it, from his very busy schedule to share his valuable knowledge and adorn the event. So we are not only humbled by your presence, but also feel encouraged. Thank you for your gracious participation. No event can take shape without its conveners and organizers. And this brings me to the point where I would like to offer my heartfelt regards to Ms. Architi Batra, convener and core team member of Sushrut, Dr. Siddharth Ashley, member of advisory board, and Soumya Pandey. It was their dedication and enthusiasm that lead to this successful completion of this event. Thank you for organizing this event. The end of a story is the new beginning for many others. On this note, let's conclude this memorable and knowledgeable event. On behalf of the organizing committee, it is sincerely promised to you that in the coming time as well, we will keep on organizing such events with innovative ideas to nourish your mind and fulfill you with more knowledge. Thank you, sir.
Thank you. Bye-bye.
Thank you so much, sir.
Thank you. Bye-bye.